I assume John's joining us.
To accept.
Yeah, I will make a slow start, and hopefully by then John will be with us, and then we'll be quorate. Welcome everybody. Good afternoon. Good to see you all to the December Primary Care Commission Committee meeting. I didn't do any chairs action between the last meeting and this one, so there's nothing to report under that. Apologies, we've got from Tracy Williams, Kath Byford, Karen Watts, and I think the LMC as well. Can I just remind everybody about declarations of interest to keep their interest declaration up to date, including close family members, and to let the team know. Mark.
Thank you, Chair. Thank you, Doris. Just to say that I will be here for as long as I can be. The system has declared Opal 4 today, so I may need to leave to chair a gold call later in the meeting, but so apologies in advance for that, but I will be here as long as I can be. So just wanted to flag that now.
Thanks, Mark. We will, if you need to disappear, you need to disappear, that's fine. Kathy?
Seems a small thing in comparison to Mark, but when on the declarations of interest, I've declared that I'm a member of the reservist nursing force doing vaccinations, but I have joined the North PCN home visiting vaccination team, so I have a particular interest in the North update when it comes on.
Thank you very much. Could you just let Martin know so that the register's updated as well? Thank you. If there's nothing else, I will move on to the minutes of the last meeting. Are there any factual or inaccuracies or questions arising that's not covered in the agenda anywhere else? I can't see any hands. I think for me on item 7 under the action, I think instead of relative information is relevant information. I think that was the only thing I spotted. If that could be changed, that'd be great. If there's no other comments or questions, I'll take the minutes as approved, and I will sign them in due course. Thank you. On to the action log. We've got the first 2 items are blue, and then we've got a bit on about the vaccination program. Mark, presumably you've talked to the comms team, and
I have indeed, Doris. Yes, so I've had a conversation with the team. It's something that we're looking at very closely now, and of course, given the latest changes around the boost program, so we had to do a lot of resetting fairly swiftly as well. But I think we can probably, I suggest we close the action. So yes, did link with the team, and actually not just a one-off. We will continue to make sure that the best information that we have is shared with as clearer as possible for the people of Norfolk and Waveney too.
That'd be great, because obviously it's a changing beast, and
certainly is.
It's good to have some up-to-date information whenever possible. Then the next one was on Spotlight for Yarmouth and Waveney. Have you picked that up, Shepherd? Off that between that was one of your.
Yeah, that is correct. Yes, we've had the conversations.
So we can close that one as well. And then the prescribing report. I think Hein was going to send some comments in. Hein's going to be running a bit late, so he will join us a bit later. If I can check with Hein off, maybe, or Sarah could just check with Hein after the meeting. If that's done, we can close that one off as well. And then everything on the action is closed, subject to any new actions to be put on today. Is everybody happy with that? Yeah. Okay, thank you. On to the forward planner. Sadie, I think we've got a few changes on here.
Yes, thank you, Doris. We've actually got a little change against a blank, so apologies for that one. I spotted that when I was reading the papers. So the two main items that have been deferred this month are the serious mental illness health checks. That report is going to come to January, and that was simply a matter of capacity to get the paper ready for today due to some leave within the team. And then the second item is the digital update, and we have deferred that to January simply because we had so much on the agenda and we had to pick some things to sort of fall off the end, I'm afraid.
That's fine. Thank you very much. And I think I had a conversation with the BI team as well. I think there's going to be a better report if we just deferred it. So we look forward to getting those updates in the new year. If there's no comments or questions on the forward planner, Peter.
Sorry, I'm very sorry I was late. It's actually just a quick one in relation to the minutes. I am sorry. Just a factual correction. The comment that I made about the 36,000 health checks, that's the position across 2021 and 21-22, not just this year. And that was it, but just for the sake of accuracy, thanks very much, and apologies again for being late.
That's fine. We'll pick that up and get the minutes changed for that as well. Thank you. So on to the risk register. Can I pass that to you, Sadie, please?
Yes, thank you. And as usual, I will focus on the risks that have either changed or the red risks. You colleagues may remember from the last meeting that Hein raised a comment about the risk scoring and how dynamic the risks were and capturing that. And we had a conversation with all the leads on that. And as a result, you'll see that there have been a couple of changes in scoring of the risks on the register. So firstly, PC3, which is around the locally commissioned services. We were hoping to reduce the risk on that one anyway, and had highlighted that, and you'll see that that has in fact happened because of the strong progress that we've been making around the locally commissioned services review. And there's a paper later on the agenda describing all of that in much more detail. There was a comment offline from the local medical committee on PC3, which was around one of the gaps in control. And that was the December meeting of the LMC, which you might remember was added in following a comment in, I think, October. You'll see in the update for December that we have captured that isn't actually relevant to the progress of the project because of the way we're now working with the LMC, but we will just pick that up in that gaps in control section and update that as well. So apologies for that oversight. PC6 is learning disability health checks, and there's a paper on the agenda describing that in more detail along with the progress. So I won't necessarily go into that now unless there are any specific questions. PC9, which is hypnotics and anxiolytics. You'll see the update from Michael there in that we are improving on that risk, but unfortunately our national position remains the same because everybody else is improving as well. So we remain third worst, unfortunately, in Norfolk and Waveney. Again, more detail under Michael's prescribing report. PC11 is around the primary and secondary care interface, and this has been an item of focus for us, working very closely with the planned care team. Mark is chairing an interface group which meets monthly. There is a fuller update later on the agenda on this, but essentially really good progress. The 3 acute trusts have come together to draft a policy which has been shared with all the members of the group, and once adopted and implemented will hopefully make quite a significant difference in terms of the work being pushed out. And then finally, PC14, which is also one of the risks on the governing body assurance framework, that risk has increased this month, and that's around the pressures on primary care. And I'm sure that won't be a surprise to colleagues here today about the increased pressures on primary care. We have done quite a bit of work in the last couple of weeks around the increased pressures from ambulance delays, which have led to, in some cases, patients obviously staying longer in the GP surgeries than they might normally under the care of the clinical teams there. We're doing some work around procuring additional oxygen supplies for practices accordingly for respiratory patients that might have to wait longer in practices. We've previously updated you about our winter access funding. We have a paper later on the agenda around that and the operational plans being developed, and that is now in the process of implementation. And then finally, quite a lot of work on our communications and engagement campaign around general practice. So I will pause there. I can see there's a hand up, and happy to take any comments or questions. Thank you.
Thanks, Sodhi. Kathy?
It's a comment really. Ambulance waits has been added to the risk register for the Quality and Performance Committee for obvious reasons. And this committee, which we had last week, we recommended that it goes onto the GBAF. So if it's going as a GBAF risk, I'm just thinking that we probably need to put the impact on primary care, add it into that overall risk.
Thanks, Kathy. I'll make sure I link in with the quality team on that.
Okay, thank you. Are there any comments or questions? And John?
Yeah, thank you, and thanks, Eddie, for the comprehensive introduction. So I've got 3 questions which might all be covered in different papers on the agenda, so by all means tell me to park them if you like. But one was on PC3, the LCSs. The latest update talks about risks around decommissioning services and patient dissatisfaction, just understanding a bit more about that. PC6 on LD, feels like there's lots of work happening, but the risk score isn't reducing. So question for me, does that mean we're not confident in what we're doing, or despite the best efforts, things aren't improving? And maybe we'll pick that up when we come to the LD update. And then PC10 on Gabapentanoids seems to be reporting good progress actually, but for that one, it was just understanding what's our target. How will we know when we've mitigated the risk to such an extent that we think we can do, and then we can take it off the risk register?
Thank you.
Take Sodhi?
Shall I start? And
Yeah.
then I might have to hand over to other colleagues. So on locally commissioned services, we've been focusing a lot on getting the service specifications right and agreeing those, and then costing them appropriately. And at the time of writing the paper, that piece of work had not been completed. So we have included as part of the project a phase of what we're calling service stratification. So for example, if we get to the point where we don't have the budget to commission everything that we might want to commission, how do we then stratify those services so that we can prioritise what we need to commission and what we don't? So the risk is a theoretical one at this stage, and things are looking quite good in terms of where we're at with costing versus budget. And actually, John, we've got a meeting, we think, with you next week. So the plan is to sort of go through all the numbers with you and with Mark at that point, and then decide on next steps.
Okay, thank you, Sodhi.
LD was the second question. I'll perhaps start, and Shepherd can add or correct me if
So
I don't.
unless we want to cover it when we get to the LD update on the agenda later.
What would you prefer to do, Shepherd?
Yeah, we can cover it later. A fair question,
Okay.
though. Yeah.
And then your question on gabapentins.
Just
I'll look at
understanding,
Michael.
yeah, when will we know that we've succeeded and delivered what we can, I suppose, because it feels like we're making progress, but I'm not clear from that how much further we need to go.
It's a good question. I mean, in my opinion, it probably doesn't need to be on the risk register, but happy to be guided. I mean, if we have another month or two stable or improving, I think we could definitely recommend taking it off. But at the moment, we're not a national outlier. I mean, we're 77th percentile, and given our population and our history with dependence forming medicines, that's actually not a terrible position to be in. Clearly, we'd like to be lower, but there's limitations on how much you can deliver of that. But a bit of stability and maybe an improvement, that you could. Yeah, I'd be happy for it to go off the risk register, and we'll still monitor it on this paper or another quality paper if it in future, so that we know where we are and we can put it back on if it worsens.
Thank you, Mike.
Okay.
Thank you very much. I think that sounds like a good plan. Review in the new year, take a decision on that one. Are there any other comments or questions from anybody else on the risk register? Bill.
Sorry, trying to unmute there. Just on PC 14, it's just the risk title is primary care pressures. It seems a very general title, and I read the risk description, but I just wondered if there was a more focused. It just seemed to, I couldn't see that risk ever disappearing. And therefore, how would we, is it too general to be a risk that could actually be managed or mitigated? It may be that actually it's general on purpose, and that's fine. But that's my question. Thanks, Bill. Do you want to come in, Sadie?
Thank you, Bill. I think what I'd like to do is probably have a think about that and have a chat with Mark outside of the meeting and come back with any update for next month, if that's okay. I think it's a really good point, actually.
Thank you, no problem.
That's great. Thank you. Thanks for all the updates and actually tracking the movements as well. It is good to see there is some movement, and we will look forward to the January one to see whether there's any movements and changes following comments from this meeting. I'll move on to Mark's report, item 7.
Thank you, Doris. And just before I kind of dive into the report, just to echo one of Sadie's comments about the interface committee, it's between primary and secondary care. Really pleasing progress I think we're making on that front. I'm really pleased with the approach that acute colleagues have come to the meeting with, likewise with, I think, really constructive conversations from primary care representatives and the LMC. So we've only met twice, but actually I think we've already started to make some progress on that, which is really pleasing to note, as Sadie said, but just echoing that. So in terms of my report, I will take it as read, but there are just a few things that I would just like to pull out, if I may. Firstly, we know access is a real hot topic, and I know we're going to discuss it later in the agenda, but it is pleasing to note the numbers, the figures are continue to look positive for Norfolk and Waveney, with nearly 89,000 more appointments offered in October this year compared to September, and that includes a significant increase in face-to-face. Also highlighted in the report and discussing, being discussed later, about the WAF funding, the winter access funding has now been approved. We actually sent the letter out today. Thank you to Fiona, Sadie and other colleagues who have put an awful lot of hard work in trying to make sure we've got the detail right on that to get out to practices, because it's not a straightforward thing, that, especially when we're trying to do this at such pace. But I think now the challenge is absolutely about using that funding to make a difference and support patients and improve and increase capacities we know our primary care colleagues are trying to do. Also really positive about the new interpreting and translation services, as mentioned in the report, and actually that contract does go out till 2025, so a real opportunity there to see improvements. And actually, you know, the deaf awareness training that's referenced in the paper, Sadie and colleagues have spent a lot of time engaging with representatives of the deaf community and those hard of hearing, and it's really pleasing to note that we're trying to do some more there, and the good connections with Here for Now, Deaf Connections, West Norfolk Deaf Association, and actually one of our winter schemes that Sadie has put forward is in relation to some of that engagement that's taken place. So it's really good to note that not just generally, that we're actually also targeting some of the work around access and improving access for our patients. And then the final 2 points, just a reference, again, it's good to note, and thank you to all colleagues around the flu and the COVID vaccination program. We're making good progress on that. The report contains some of the numbers and the figures. It's very hard work for our teams and also for primary care and wider colleagues, especially given the latest. You know, it almost feels like it changes overnight, and we set off on one path and then very quickly everyone needs to change. So I think it's important to acknowledge that and thank the teams. And finally, just we mentioned last month about the campaign to support primary care. That's now 3-4 weeks live. We've had some really good feedback. The teams are doing some great work engaging on things that I don't understand very much, such as social media, but also on the radio and other means. So I think that's progressing quite well, and of course we'll bring further updates in due course. So just a few points to highlight from my report, but happy to answer any questions if there are any. Thank you.
Thank you, Mark. Are there any questions for Mark? I'll kick off. In the paper you talked about a PCN withdrawing from the vaccination. Are we confident that there is sort of provision close by that people in that area can easily access? And I suppose supplementary to that is, with all the more recent changes, are we sort of confident that we can flex, you know, the number of slots locally to meet the new requirements?
Yeah. Are we confident? We don't have the final answer yet in all cases, Doris, but I'm confident that all the work is being done to ensure that we do. And that continues, you know, engagement with PCNs and with practices. I think it is our job to make sure that there is that access available in the right places. For example, it's an easier discussion in Norwich if we were to decide something near the Norfolk Showground, for example, or the Norwich City Football Club, then that presents certain options. But in North Norfolk, for example, we're thinking one base wouldn't necessarily meet the need of the population, so we're considering all options there. But so are we confident? No, I think work is still ongoing, Doris. I'm confident that we're doing everything we need to try and make sure we come up with the right answer, if that's helpful.
Yeah, and I assume that there is going to be sort of regular communications update, especially where a PCN has withdrawn, and you know, where people have had their first and second jab at their local surgery or wherever it was, and they might assume that, oh, we'll just go there, and it's not there anymore, and that just needs managing. Absolutely. So another case of communication will be key. And timely communication as well, and it's going to be tricky to make sure everything aligns, but absolutely, Doris, communication not just to patients but also our teams, this committee, and making sure that everyone is aware of what's happening. Absolutely. Thank you, Mark. Andrew.
Yeah, can I just, similar to how I commented last month, really, there still seems to be difficulty between having two parallel systems, and the patients who present to vaccination centre in Thetford often make the comment that they've attempted to make a booking because they're encouraged to do so by all the advertising that goes on. So they log on to the national system and of course can't find our local PCN clinics. And that still seems to be a big problem and causes all sorts of confusion in our patients. to the extent that there are now people turning up at the door unannounced, just because they know where it is, to come and physically sort it out, which of course puts pressure on the admin staff. Although I must say they are brilliant, only speaking, about one particular place, but their adaptability and their ability to try and sort the patients out in a timely and kind, above all manner, is really good. But I still wonder, something's not right, and we still have this confusion in the messaging. It may be at a national level, I don't know, but is there anything being done to sort that?
Yeah, we certainly see it nationally, Andrew. It's not just a local issue. So in a perfect world, one could suggest that if everything was available on the national booking system, then it would make things far more straightforward for individuals. But there is some, some practices PCNs are preferring to do it a slightly different way so that they can make sure their population is served. So they have very understandable reasons for choosing to do it a slightly different way. It is a conversation we have pretty much daily, Andrew, but there is that people are not forced to go onto the national booking system, as in supplying the vaccine. So it's a live one, but I accept the confusion and less than ideal in all situations. But we continue to try and work through it to make it more straightforward. So that's a bit of a woolly answer, but
yeah, I mean, just maybe just as a simple practical suggestion, perhaps the option of people being contacted by the local PCNs, which I support because that's being done by people who know their patients rather than a remote system. Perhaps that should be put further up the kind of pecking order of choices, because it's very much at the bottom as an afterthought.
Yeah, that's a good suggestion, and we'll feed that in. We also do mention this frequently to the regional and national teams about the confusion and that some of this is causing. But it's a very live subject, Andrew.
Great, thanks.
Thank you very much. Are there any other questions for Mark? No, I think thank you, Mark, for the update and the report, and no doubt there'll be more changes between now and January. On to item 8, which is the locally commissioned service. Sadie, are you taking that with Gina or just you?
I think I will take it because that was Gina.
I thought so.
Thank you. So I'm sorry Gina's not here. She would do a much better job of presenting it than me, as the person that wrote the paper and has been doing a lot of the detailed work. I'll make an assumption that colleagues have read the paper already. So what we're asking is for the progress that we've managed to achieve up to now to be noted, and then for the committee to support the process for practice signing up and the engagement process moving forward. So as you can see from the paper, there's a table which spreads over page 1 and page 2, which sets out for each of the specifications exactly what stage of the process we're at. I have to give thanks to the colleagues in the local medical committee for this. They are a small team and they have been churning these through for us as quickly as they possibly can. So we're making very good progress, and in fact the black block can extend a little bit further now into the other specifications. Next steps for us now, I mentioned a bit earlier about the costing work that has been done. That is now nearly concluded. We will be in a position to be able to demonstrate to individual practices what they have previously been funded for delivering the services against what they would be funded in future for delivering the services which practices are very keen to receive. And as you can see there in section 3, we are now planning out the actual launch of services, which we expect to be pretty much as soon as we return in the new year. So starting off with making sure that practices have absolutely all the information they need, attending meetings to provide information, and then holding a series of drop-in sessions for practices to attend with us. And then by the end of January, for practices to have indicated what services they are planning to sign up to, and we really very much hope that practices will sign up to all of the services. Clearly, after that point, if there are any gaps, then we need to work through those within the primary care networks concerned to ensure that services are integrated as much as possible, and so that we can make sure that any gaps in provision are resolved by the time we go live on the 1st of April. So next steps are just to finalise all the service specs following consultation and the input from the local medical committee. Gina's currently going through a process of reformatting all of the specifications. As you can imagine, they're all slightly different, having come from 5 previous CCGs. So we're going for a really simple single format. We'll go through the exercise to determine affordability, as we mentioned earlier, and then prepare the paper for final sign-off. And we do have a separate meeting of voting members arranged with the local medical committee as well to sign those off before we finalise the launch details for practices. So I'm hoping that's a comprehensive update and demonstrates the enormous progress made again in the last few weeks, and happy to answer any questions, but I very much appreciate the committee's support for our process going forward, as noted here. Thank you.
Thank you, Sadie. Are there any questions for Sadie? John?
Yeah, thanks, Doris, and thanks, Sadie. It's tremendous progress, isn't it? It's good to the fact that we're still on course for what's a really involved and complicated project. So thank you for that. Just a couple of questions. One was, and I think you alluded to it in what you said, Sadie. Presumably practices are entitled to sign up for which services they would want to sign up to. It's not an all or nothing approach, so they don't have to sign up for the whole range of LCSs or none. So I presume it's sign up to the ones that they might want to sign up to. And the other question in terms of the launch and engagement was, is it just the CCG team doing that, or is the LMC kind of alongside? Will the comms come from CCG and LMC? Will they be involved in some way in any of those briefings, just to emphasise the fact that it's been that kind of joint approach throughout?
Yeah, thank you, John. So regarding the first question, I think we are encouraging practices as part of considering sign up to think where things might be better achieved at scale and where things might be better delivered at individual practice level. It's certainly not an all or nothing approach, but it should be noted that it will be more challenging to commission single practice services in some cases. So as part of the implementation, we will want to be we will want to be talking to practices in their PCN groupings about sign up and implementation, and to work out the best way forward, balancing our principle for this review that services will be consistent across Norfolk and Waveney, and against obvious practice views and practice resilience issues. So I think we'll say more on that as we move through the project and work that through. The second point was on your second question. Sorry, I didn't jot it down in time.
Just whether the launch and the engagement process is just the CCG, or whether the LMC will be alongside, recognising the good joint work that there's been done.
Yeah, I think in terms of comms, I think we have agreed that the LMC has a different role to the CCG in terms of representing its members, so the communications have been kept separate at this stage. The meetings and so on will be just CCG officers. However, at every stage we are talking everything through with the local medical committee and where possible agreeing on wording, communications, etc. And Gina is having weekly meetings with the LMC so that we can achieve that. So it does feel like a very joined up approach, recognising that we have slightly different roles within this.
Okay, thank you.
Peter.
Thanks. Sadie, just I guess in acknowledging you and I have already had some conversations, because obviously we intend to do a similar process next year and have said so in our commissioning intention, so I recognise on a far smaller scale. I think it's addressed here in the risk under clinical and quality, but certainly in the public health elements of LCS, we take the same approach. We offer it to everyone and hope that everyone will sign up. If nothing else, that keeps us on the right track from a procurement perspective at our side of things. However, in a practice determining that it wishes to sign up, we also have some expectations around additional training and that type of thing. Typically with sexual health, for example, that's around the letters of competence or the diploma. Are there similar aspects, and is that explicitly sort of addressed somewhere here? Because that would be helpful to almost take a similar line that says it's not just enough to put your hand up to deliver. By doing so, you're making certain commitments around additional, you know, over and above your sort of GMC qualification or whatever about training. And so it might be just helpful out away from this meeting to match some language around that. Thanks.
Yes, of course, and we're very happy to share the specifications, and you're very welcome to use the new template that we've developed, and it has a very clear sort of competency requirement, and that is reflected in the way that we've costed the service as well, recognising that it takes time to go through that, and if it's a requirement of the service, then it needs to be costed in as part of service delivery. So yeah, very happy to share that with you offline.
Thank you very much. I see Gina's just joined us. Thank you for all your work. I mean, it's actually, I'm not sure when you have time to sleep, but thank you for the progress you've made and your team have made. You know, when we first started talking about really getting this going, it was always one of the fears was how is it going to be achieved, and it's really good to see, you know, it's been fantastic progress over the last few months. And I know we're not over the line, but it is really, really good to see. So thank you, and I'm glad that you managed to pull up somewhere safe and join us. Are there any other questions for Sadie or Gina? No, so we are asked to, sorry, I'm just trying to find the beginning of the paper, to note the progress and to approve the process for practices to sign up. And I think the voting members have a meeting just before Christmas. Is that right? Yes. Yeah, it is, isn't it? So that's our Christmas present to ourselves, to have another meeting. So if everybody's happy with that, I don't see any shaking of heads. I take that as approved. Oh, we've got a thumbs up from John, so that must be all right. So that's great. Gina, thank you very much for your work, and keep plugging on. And we look forward to getting the final report to sign off.
That's great. Thanks, Doris. Apologies for being late. I had a power outage and the mobile phone signal's down in our area as well, hence the drive. But apologies for missing it.
Not a problem. I'm not sure if I'm frozen actually. Could somebody just tell me what am I? Oh, I think I froze. But
we can see you, Doris.
Yeah, I'm back, so that's fine. And so we'll move on to the paper on primary and secondary care interface.
I have asked Lois to join earlier, but
she is. Thank you.
She's in.
Hi. Thank you, Chair. So just a few points to highlight from me. Firstly, the interface group has now started. We've had 2 meetings. The main area of focus has been developing an interface policy, and the purpose of the policy is effectively to pull out all the main interface contractual requirements into one document, and these are areas that are frequently causing issues between primary and secondary care, just to clarify roles and responsibilities. This document should be finalised this month, and then the next plan will be to develop a comms plan around this so that we make sure we implement it. If we don't get the comms right, then it will all be pointless. So our CCG comms colleagues will be leading this work and will be working with their system partners to develop a plan. In addition to that work, a small working group will be established to look at developing a system-wide process for resolving and escalating interface issues. At the moment, we have, well, frankly, a lack of process in most areas. We've got practices which can raise issues through a certain email address, but it's clunky, it's not simple. We have no process for secondary care to raise issues to the CCG. And we really need a straightforward process for everyone to use, which enables quick resolution of the issue for patients, but also enables the CCG and providers to have oversight of the issues and identify themes and trends which we need to learn lessons from and change things potentially. In addition to this, obviously, there are issues on the secondary care side of things, and we need to make sure that we're supporting secondary care colleagues where we can on the interface. So we will look at developing some guidance to improve the quality of referrals from primary care, for example. So in summary, I think some good progress is being made at the interface. The conversations that have happened today have been very constructive. There's definitely a will to improve things. Engagement is positive. But I think, like everything at the moment, the challenge will be how everyone fits this work in with all the other asks that they have at the moment. It's a challenge for everyone, but the will is certainly there. Can I please ask the committee to approve quarterly updates to be provided from the interface group? Thank you.
Thank you. Thank you, Lois. Are there any questions for Lois? Can I just ask a question about, I know, we're talking about contractual relationships and the interface between, secondary and primary care, that we don't lose sight of patients in all this, because patients are basically the piggy in the middle that get caught between the crossfire. And I think we do need to, bear that in mind when we have these discussions. It's a personal plea for me, actually, but
no, you're absolutely right. Absolutely right. It's the patient that will suffer if we don't sort these things out.
Yeah, that's great. Thank you. Are there any questions for Lois? No. Are we happy to agree to quarterly updates from the group? Great. Thank you very much, Lois, and keep up the good work, and let's hope we can crack some of these sort of thorny issues and make things work a bit smoother for the benefit of patients. Thank you.
Thank you.
Moving on to the second half planning. Fiona, do you want to take this?
Thank you. So this is a paper that was shared in draft format at the last meeting in part 2, as plans were not yet approved. So we're now asking for formal committee approval for the plans for the second half of the year, and also to agree the winter access funding plans. In terms of the winter access funding, as already mentioned, we've sent out a letter to practices, and we've also had a meeting with Region today to discuss progress and the reporting setup going forward, which will be on a monthly basis and in line with the template that they've pulled together. there have been a number of minor changes to the plan since, not surprisingly, I think it was put together so quickly that on reflection, when we sat down and looked at it in cold light of day, but they are minor changes. And one of them is around looking at the community pharmacy workforce. And we've got some plans we're exploring there to support them. And we've also looking at the services for supporting and enabling members of the deaf community to access services, as has previously been mentioned. And the other change, there has been a slight change to the practices that will be participating in the Access Improvement Program. Again, reflecting on the reasons why the initial list was selected and having follow-up conversations with them, it's become apparent that some practices would benefit from the continuing enhanced support that's already been provided from within the CCG, and there are other practices who would benefit from an accelerated access improvement programme. So there has been quite a slight tweak, and we now have 10 practices being put forward for that support, which will start very shortly and last about 20 weeks. That's all the updates I wanted to give you, but I'm happy to take any further questions.
Thank you, Fiona. Are there any questions for Fiona? I just had a, sorry, John, you come in first.
Sorry, Doris, I was slow on the button there. I suppose my only question would be, it's clearly really positive that we've got extra money to put into a number of different services in the second half of the year. The concern with all this is what happens when that money runs out in a few months' time, and there's clearly expectation built in the system about services that maybe people are expecting to continue. So it's just really a question and maybe a plea that the exit planning for this as at 31st of March is looked at early as well, so that we can manage expectations and also understand any implications, I suppose, as and when the money disappears at the end of March.
Yes, thank you, John. And I think, yes, I think that's a good point. Obviously, all these services were made aware that the funding expired at the end of March. So some are already making plans, but yes, absolutely, we'll look at that very carefully. Thank you.
Thank you. Andrew?
Yeah, just a couple of things from the point of view of talking to patients and trying to express views. You've got a list of when to access funds, and they're numbered as NNW 9, which mentions about development of PCN call centre hubs in the future. I don't know anything about beyond what it says. I don't know anything about the detail of that, but that I suspect would be an unpopular move for patients, because that rather sounds like call centres and banking and all that side of things. And I think people really value being able to speak to the local surgeries, and many people have developed relationships with the local staff over many years. So I'd really caution against any move towards developing PCN-centred hubs. And the other just couple of things is, I don't think our patients will have heard of community pharmacy consultation services or discharge medicine services as provided by pharmacies. And we know about these things because we're in this world, but the general public doesn't. And again, I think that's back to another communication issue. These things are just not talked about, not heard about. And I fear, going back on the feedback at Healthwatch, the terms people use they use rather derogatory terms like fobbed off. So when a patient is directed to the pharmacy, maybe entirely appropriately, they regard that as being fobbed off, which is sad and wrong. But I think we do need to do better and communicate what that means and why that is, and also defining what is a minor illness, because of course what's minor illness to me is not minor illness to somebody else. And just one more thing, and this the whole I've gone on about this before, I know, but the whole balance between access, and we seem to get a lot of talk of access being so important, and I would counter that with continuity, professional and personal continuity. That actually results, and there's evidence for this, that results in better outcomes. But there is a balance to take. Thanks.
Thanks, Andrew. Fiona, did you want to come back in?
Yes, so on the PCN hub, I absolutely recognise what you're saying, Andrew. The proposal in there is to work up a business plan and look at it and review it, so it's resources to do that work. And obviously looking at the digital and telephony aspects of it, but I agree, looking at it from the patient perspective, and we need to involve and understand the patient view if in looking to develop the business case for this. So yes, very important part. And the second one, role of community pharmacies, I absolutely agree with you in terms of their role and how critical their role and the awareness that patients have, and some of the resources that we've put into the plan are to support the comms and engagement around that, and making sure it. Yes, there's an important point about making sure it's the right people who are being signposted to community pharmacy for the right reasons, and it's about supporting the whole of primary care to deliver services to patients, and how each other services can support each other, but it's not without its challenges. I totally recognise that.
Okay, Sue?
Thank you, Sue here from Health Watch Suffolk. Just really excited to hear about, on 2 occasions now, the engagement work with the deaf community in accessing primary care services or the care services. I was just wondering, I probably already should know this, but was that done as a group engagement, Fiona, do you know, or was that done on an individual basis, or do you know how that was done, the engagement process?
So there's been a lot of, I suppose, email correspondence, but actually we met with representatives from the deaf community in August, and they were representatives from across Norfolk, and we are meeting with them again, in fact, next week to follow up. The first meeting was very much about us listening to their concerns and trying to understand what the challenges and barriers they faced. And the second meeting is an opportunity for us to feed back on what we're doing and the range of initiatives we're putting in place, but also to listen again to see if their experiences are changing. So it is an ongoing process, absolutely, and not something it's just going to be, 1 or 2, but we need to keep them engaged.
That's terrific. Thank you very much for that, Fiona.
Bill?
Thank you. I'm very interested in what Andrew was saying about patient, and I think he's absolutely right in considering the patients. But what I would caution against is that all patients being the same and thinking the same way. Now, if you've had a chronic illness and you've been dealing with the pharmacy for, I don't know, 8 years in a particular way, and somebody wants to change it, I understand why there'd be immense resistance to, the way you interact with the surgery. But actually, younger patients or people whose lifestyle doesn't centre around, I've got plenty of time to go have a trip down to the surgery and meet by person face to face because I've either got a job or young children or whatever, it's much more different. So I think that we need to look at a broad spectrum of approaches, and just because some patients don't like the idea of new doesn't mean that there would be others that don't. And the ones that tend to make the most noise are the ones with the most time, in my experience. And therefore, it is difficult. I understand that, but I do think that PCN hubs and stuff may be one, helpful for a resource issue and supporting, but also as an opportunity for somebody to get a quick answer to a particular issue who doesn't require a face-to-face visit. So I just think in terms of our approach, we need to be aware there's a plurality of approaches, which I think will help the whole system, so that does free up the face-to-face appointments for the people who really need it, for example. And the other thing on the community pharmacists, I think this is excellent. And again, I know nothing about it, so the more that we can share that, and the more we start to talk about it, so that the first time somebody doesn't hear, is when they want something else. So if we need to tell people about these options when they're well, so that when they then choose them when they become requiring of a service, and whether there's some information that we could use as part of our communicating with the lists, not just with the people who are wanting appointments. Anyway, a couple of thoughts there.
Thank you, Bill. I just had a question really in relation to sort of the discharge medicines, whether we'll resolve the issue around practices that have dispensaries, and it's back to what patients are used to, and unfortunately it's if the medication is sent somewhere completely different when people are discharged from hospital, it might just flummox people in the time of, their life is quite stressful already. And have we managed to resolve that conundrum?
Yeah, I think this is a good point. And in terms of the reliance on community pharmacy and sign up and referrals into community pharmacy, and also the dispensing of medicines, we do have to recognise the rurality of Norfolk, and the fact that some patients may have to travel quite long distances for prescriptions. So we need to be aware, and we have been discussing that with our colleagues in the region, certainly in relation to the CPCS sign up, and how we can manage that. But yes, this is an issue. I'm not sure if any of my colleagues want to add to that.
I just wondered whether there was, whether there is an option where for rural practices that have pharmacies to actually link into that. I don't know. I don't know what the specification is. Whether that's a way of resolving it. Michael, did you want to come in?
Well, just to say that, I mean, most of our rural pharmacies have access to a pharmacist, and the pharmacist could field these discharge medicine services. The only issue is that, not being pharmacies, they're not going to be reimbursed the relatively small amount of money that pharmacies get paid to do it, but that it is the right thing to do to prevent unnecessary readmissions due to medication errors or administration errors, things not stopped in a timely manner, things continued when they've been changed, etc. But I mean, there's members of my team who are working on implementing this and CPCS, but it is still work in progress at the moment, because the hospitals are relatively busy doing things. They are sending referrals out for DMS, but we've got a fair way to go to get the numbers up, I think is the simple way of putting it.
Okay, thank you. Lois.
Thank you. Just a comment really about community pharmacy and the importance of integrating them within the PCN, because we need to see them not as a separate body that could be sort of second best to seeing your GP practice, but actually part of the healthcare offering. And there's work going on now because of the hypertension case finding enhanced services now with community pharmacy to start that integration process. And I think that's really key to change maybe some of the patient perspective of community pharmacy being sort of somehow lesser.
Okay, thank you. James?
Yes, a couple of things, if that was okay. I wanted to clarify that a telephone appointment doesn't save the clinician or GP any time, it only saves patient travel time. It takes just as long. So the balance between access and all of that stuff is interesting, but it isn't going to, we aren't able to do more. But secondly, there's a lot of talk about community pharmacy, but there's a real crisis at the moment. I had a meeting last week, for example, with the local pharmaceutical committee and the LMC, in which I was facilitating, because there are so many temporary closures of pharmacists because they can't find a responsible pharmacy to cover the shifts. This is in Norwich, and I appreciate that other areas are equally effective, but I can't comment on those. So we are literally talking about patients not even able to get their medication. We're talking about patients contacting us saying, I've used my last painkiller to get to the pharmacy and I can't get my medication. What are you going to do? And so we are being presented with a large number of patients presenting as urgent, with having run out of their medication, with community pharmacists taking up to 7 to 8 days to dispense medication. And one of the aspects is that, for example, because they don't get on top of it because of their workload, it means that you see queues outside pharmacies, because when people are presenting, they're having to wait 20 minutes for the medication to be made up, as opposed to collecting it in a 2-minute transaction. So actually the capacity of the pharmacists to offer any form of minor injury service is really limited at the moment. And I'm currently trying to work with them to agree a consistent standard operating procedure in which, if they do have to shut, so for example, one pharmacist in a well-known supermarket near us shut for 4 days with just a poster. And so what the patients are supposed to do with that, goodness only knows. Anyway, we had a chap turn up who'd run out of painkillers with a partially amputated foot. What was he going to do? And so all of these are presenting. So there is a real issue, and I know recruitment is a particular issue, but I just want to add some context to the community pharmacy service, which is it is buckling under pressure. So I don't know if that's helpful to the discussion.
Thank you, James. I mean, I was in the city at the weekend, and I think there was no the pharmacists at the Boots in Castlemaine were shut because they were off sick. So these things are happening. Rosemary.
Yeah, I just really wanted to concur with James's point, because I think just our impression, certainly in the south, is that just pharmacists across the board are in short supply. Our PCN has desperately been trying to recruit clinical pharmacists, and there just aren't any pharmacists basically at all. So I think the expectations of, as James has said, expecting the community to do more, is they're going to really struggle.
Thank you, Rosemary. Michael?
Yeah, just a further comment on that. As you can see on page 57, it says there's 72 current vacancies in community pharmacy. It's probably a bit more like 80 at the moment. And on the subsequent paper, the Norfolk Spotlight, it highlights that, you know, from nowhere, we've now got 15.4 PCN pharmacists, and most of those will have come from community pharmacy. So it is an issue that, you know, the workforce strategy has kind of stabbed itself in the foot to a certain extent. So you know, whilst it's good for PCNs, it's not so good for community pharmacy, and the whole system has been slightly destabilized. And you know, a lot of my team has gone to PCN and the CSU team. So it is an issue. There are people working on it, but it's not going to have any quick solutions, and it will limit the delivery of some of these services. But pharmacists are, you know, balancing their priorities at the moment.
Thank you, Michael. If there's no other comments or questions, can I ask for the committee to approve the paper for the half-2 plan? Yeah. Yes, I think that's been approved. So, and also the process for the winter access funding as set out in the paper. Yeah. Okay. Thank you. Thank you, Fiona, for the update. I'm going to move on to the Norfolk Spotlight. I thought I saw somebody. Yes, Sally, welcome.
Hi, I'm going to hand over to Sarah, who's going to run through some of the salient points. Sarah, are you?
Thank you, guys. Can you see me? I'm having problems with the video. Oh, there we go. Lovely then. Thank you and welcome everyone and good afternoon. Just wanted to go through some of the more pertinent points, as Sally said, of the paper, as I assume everyone's taken it as read. So I just wanted to highlight some of the key areas. So first of all, Pcn maturity. So as you'll have seen from the paper, and as Michael was just saying, we've increased a lot of the ARS staff. And the way that PCNs are looking at this now is a little bit more of a practice or PCN approach of MDTs. So instead of just having one pharmacist, one physio, one of each of everything, now that we've got a bit more money in the ARS funding pot, they are looking at how those types of roles do interact with each other, so they can have a nice sort of like an out of hospital team, or perhaps a home visiting team. So we're starting to see a little bit more strategy with the PCNs and with the ARS roles that they are employing, rather than just one of each of them, to see how it is and trialing them. So really pleased to see the strategies emerging for each of the PCNs and seeing which direction they're heading. They're starting to diverge a bit, with some of them looking more for home visiting, some of them looking more for a mental health approach. And it's really heartening to see them looking to see what their local needs are and responding to that with the ARS strategies. So that's a really key point of PCN maturity, and we'll be continuing to support them with that going forward. Secondly, I wanted to highlight the vaccine programme. So quite a high profile news item. The vaccine programme has been going very well in Norfolk. We've been consistently high performers in the PCG, and regionally and nationally. Norfolk has done a very high amount of first and second doses to get a very high proportion of our patient population vaccinated, and we're continuing into that with the boosters. And we've actually been meeting with our PCNs today just to look at what their short and medium long-term plans are. So continuing to vaccinate into the new year and indeed beyond, for whatever may come for a second booster, or whatever may come after the first lot of boosters. So they're all very much looking forward, looking at what they can provide, and to continue with that delicate balance between business as usual and also providing a very high-class vaccine programme for their patients. So very proud of the efforts that the North Norfolk PCNs have done in the vaccine effort. And also on that, I just wanted to highlight a project that's been running. So NNPC, our GP provider, one of the PCNs, NN1, and NCH&C, our community provider, have been looking at new ways of providing housebound and care home vaccinations. So instead of previously where we would just give a list to NCH&C for the flu vaccines, they've been working closely together to allocate specific days for practices to book in patients in a more robust way, to make sure that COVID vaccines and flu vaccines have been done consistently early in the season, and to try and get as many of our vulnerable patients vaccinated as early as possible. So we'll be looking at the feedback from that and evaluating that to see how we can take that forward. And then just finally, I just wanted to touch on the resilience. So last time we came to you with the highlight reports, I believe that the Chroma and Culture Cqc reports hadn't been released. So this is a little bit old news, but since our last report, Chroma is now a good practice, and Cold Shores requires improvement, which is an improvement on that inadequate rating that they had had. Cold Shore, we continue to work with them on their action plans, and they're making great strides towards where they need to be for a future re-inspection. So we're very pleased with the progress that the two practices are making and the engagement that they're doing. They were the points that I wanted to highlight to the room, but very happy to take any questions on the paper, or any other questions you may have about North Norfolk.
Thank you, Sarah. Thank you for the report. It's really good to see all the things that are happening in the locality and in the recruitment, and also they're sort of moving forward in terms of thinking about delivering services as well. So that's really good to see. Thank you. Are there any questions for Sarah on Kathy?
Hi, Sarah. Thanks very much. Interesting report. I just want to ask about, so on your LDG agenda, you've talked about the NCH&C Community Services Review, and I was wondering about the interface between the community services that NCH&C provide and all of the other people that are kind of employed within the PCN. I come from the heady days of primary healthcare teams, you see, so I'm just wondering, you know, how are you moving towards sort of integrated working across the whole thing?
Yeah, of course. I see Sally, but did you want me to, or did you want to go?
I'm happy to come in there, Sarah. So what we're doing is we're utilising as well the community transformation funding opportunity to drive forward some collaborative working across the teams. And a local delivery group we see as our overarching board, and we report back into it, you know, in a small b sort of sense. We report back into it what the progress is that's been made in terms of collaborating and driving forward a single team, no matter who people work for. So that's been really well supported with attendance at a task and finish group from our community provider, from our GP provider organisation, from our clinical director, from our NN1, imaginatively called NN1 PCN. And that is where we came, we were able to deliver the alternative to NCHC vaccinating housebound model this year. So it's what we try to do is you know, put through any sort of strategic priorities or objectives or high-level inequalities work at a system, a locality system level, and then drive forward the sort of delivery through task and finish groups, which report back into it. We then very conscious that we're linking in with Jenny Starling, who's the community commissioner, to make sure that we're sharing what we learn there, and pick up from Jenny if there's anything she's aware of that's happening elsewhere in the system to feed back into it. I'm not sure if that was answering your question, Kathy. Was that going somewhere towards it?
I think it does. I mean, yeah, I kind of am hearing that you're kind of giving the people the opportunity to work together and solve problems that need to be solved based on health inequalities data, which is kind of what I was interested in. Can I just ask, are social workers and health visitors part of that, recognising they're very thin on the ground?
No, so we have Sonia Kerrison, who she's a joint post across NCHC and Norfolk County Council, so covers the social care element side of things. In terms of health visiting, we don't have a health visitor. You know, we tend to have organisations as opposed to, and I'm not sure if Sonia would cover that off in that respect, or who would be representing the health visiting organisations from within that group. So yeah, specifically, no, we haven't got that health visiting specific link, but I think we've probably got inroads into where they're being sort of supported and provided from. And in terms of the NN1 collaborative, yeah, what our idea for that is that we will roll out to everybody that's in that area. So our VCSE colleagues, you know, whatever is being, you know, if we're in a PCN that's got, for example, Cromer Hospital in it, you know, it's starting to bring everybody together so we can look at where the need is and where we need to surge workforce, or where we need to where we have a particular issue where we've got to have some, you know, specific support. We have a forum where people can adapt and be flexible. I mean, it is early days, and we've managed to achieve the vaccination of the housebound through it. But the ambition is that we will build on that and add in as we do so.
Thank you. Hein?
Yeah, thanks. It's a very good overview. I had a specific question around the PCN manager. I read NN1 and NN3 are in a recruitment process. So can you share a bit more what that role is? Because as I understand it, is not one of the ARRS roles, but maybe it's needed because ARRS roles or take pressure off the clinical director, but maybe you can share a bit more about this. Thanks.
Yeah, absolutely. So exactly as you say, it's not an ARS role. It's an additional pot of funding for us 6 months. We don't know if it's going to be recurrent. So PCNs are recruiting at risk for this. But some of the PCNs are seeing the absolute need for that and looking that they would reinvest some of their PCN funding to continue that role. Exactly as you say, ARS roles, you get funded for the actual people themselves, so for the wages and the on-cost, but there's a lot of mentorship, management, working out rotas, lots of administration and HR that goes into a lot of those roles, into making a PCN tick over, including IIF, so the investment in impact fund metrics, making sure that everything's working. And each year the PCNs are growing and growing. We're seeing bigger budgets that they're having for staff and for other areas. The PCN development funding going in just keeps growing and growing. The need has become that actually they do need that manager there to sort out the rotas, because exactly the reason that you've highlighted. This is falling to our CDs, who are doing this on top of another job, a clinical role as well, and it's eating into their evenings, weekends. So the need for a PCN manager has become very pertinent this year with the amount of work going through PCNs, and they're recognising that need to employ the PCN managers.
Thanks, it's very helpful. I had not realised it's non-recurrent, so I think before you joined, but John Ingham made a similar comment that the risk of non-recurrent funding is that an expectation gets created, these roles will continue after March. But no, thanks, that's very helpful, Sarah.
Are there any other comments? Bill?
I think that point about the non-recurring funding is very interesting, because I was in the ICS Partnership Board this morning, and place is going to be a key part of the new ICS structure, and PCN is going to be really important to that. So I think it would, my sense of reading the rooms is that there's no way, given the overall strategy of the system, that this money is not going to be found somewhere by the new ICS going forward, because of the key role that place is going to be playing in the wider determinants of health. So it would seem to me that I absolutely appreciate it's a risk, but it does look to me that it's in line with the broader strategy of the ICS as a whole.
Absolutely. Unfortunately, the funding is national funding from NHS England, so I'm hoping that they will recognise the role and continue to fund that one, or if we could find it locally, absolutely. That would enable the PCNs to have that managerial representation at meetings and be a bigger part of the place. Because currently all the practice managers themselves, so the 19 practice managers of North Norfolk, will each do a little bit and support their PCN, but it would be absolutely great to have that dedicated PCN resource to be the voice for the PCN.
Thank you very much. Are there any other questions for Sarah or Sally? No.
Actually, I've just got a point to add to that. Sorry, Doris, I apologise. I mean, from my position and with public health, I'm keen that there is going to be a public health lead at place level as well, and that we can find some resource. Now, it's not agreed, but it's certainly part of my ambition that there will be investment, certainly from public health, in place as well, to support, working with primary care. So, I think that the place agenda is going to be hopefully invested in not only by the health service, but also by social care and public health.
Thanks for that, Bill. We look forward to the future. Thank you, Sarah and Sally, for joining us and for your update. It's always good to hear from you and see you as well. So see you hopefully in the new year sometime.
Thank you very much. Bye.
I'll move on to the two CQC reports. Shepherd, are you taking this?
Hello, Doris. I'll take those. It's Carl here.
Oh, hi. Thanks, Carl.
That's all right. Good afternoon, everybody. I'll take the papers as read. However, I'll just give a brief update. We've had two reports come in the last month. The first one we'll discuss or report on is High Street Surgery, previously reported as RI on the 17th of April 2019 and subsequently re-inspected on the 23rd of August 2021, and they still remain as RI. The CQC found breaches of regulations and insists that the provider must ensure care and treatment is provided in a safe way to patients and establish effective systems and processes to ensure good governance in accordance with the fundamental standards of care. Also, the practice should continue to improve engagement with patients and also continue to review and reduce where appropriate prescribing rates of hypnotic, psychotropic and opioid-based medicines. In order to seek assurance that these are being met, the delegated team, quality team, meds management team and the Great Yarmouth and Waveney primary care locality team are meeting with the practice on a monthly basis to ensure an action plan is put in place and to seek assurances that the practice are moving in the right direction to satisfy these areas as highlighted. In terms of the second report, good news, Upwell Health Centre were previously inspected on the 13th of February 2020 and found to be requires improvement. However, following a further inspection on the 17th of September this year, they are now rated good across all areas. However, the CQC have pointed to some areas where they could improve, which are review and improve their systems to monitor and manage staff training, review and improve domestic abuse training, continue to improve uptake with cervical cancer screening, continue to improve the management of patients with long-term conditions, and continue to monitor and improve prescribing of medicines where prescribing is higher than expected. Again, although they are good, we are still liaising with the locality team along with other teams within the Norfolk and Waveney CCG in order to support the practice in meeting these areas where there have been improvements or improvements are required. Happy to take any questions.
Thank you, Carl. It's good to see Upwell's improvement, and High Street obviously still have some way to go.
Yes, yeah.
Kathy.
I had a question. I read the reports behind this, and it just struck me in relation to the High Street that there were kind of some first order issues and sort of some things that will be a sort of more of an improvement trajectory. And one of the things that jumped out was, I don't think it's the right form of words, but, you know, medication notices and being able to respond appropriately to them and make sure patients were prescribed the right kind of combinations of drugs. And I wondered, is that a fairly quick win? I mean, presumably other surgeries have a system in place to deal with that. And so it struck me as something that shouldn't be on a trajectory. It should be a kind of let's do that now, because that would be safe.
Yes, the medication review team are working with the practice. I don't know if Michael wishes to comment, but we are aware, you know, we are working with the practice to support that. So that should be a relatively quick win, Kathy, as you quite rightly say. John.
Yeah, thanks, Carl. Also on High Street, obviously, and concerning reading it cold to see that the three domains that the practice was found requiring improvement 2.5 years ago were still requiring improvement after that period of time. And there's an obvious question there about what's happened in the interim within the practice in terms of the support we may or may not have been able to provide. Is it a capacity issue? Is it what are the issues that means that there's been no obvious improvement from a CQC perspective? And the second point, which ties back to Kathy's point a bit, that the paper stating that the practice doesn't always provide care in a way that keeps patients safe. So in terms of assurance for this committee, what's happening today, tomorrow, to make sure that patients are safe alongside the longer term action plan?
I'm aware there have been workforce issues within the practice, John, and they are seeking ways to recruit, and they have recently recruited another nurse. So working along with the locality team and meeting with the practice once a month and put in place an action plan, we're pretty sure that these can be addressed.
Is there more assurance that we can get than that? Sorry, Carl, it just seems that this is significant poor rating, isn't it?
Yes.
And it's been there for a long period of time, and it feels like, again, reading it cold, and I haven't gone into the detail behind it, things haven't improved. So I think we need more assurance in terms of what is going to change this time. And also, as I say, there's some fairly stark statements in the paper that's in the public domain. So I think we just need to be clear on what is it that is being done to keep patients safe.
Okay, John, I'll take that away and discuss this with the locality teams in order that we can seek further insurance and report back next time. Is that it?
Personally, if we have something come round before the next meeting, because again, if there's a report out there that's saying, that's questioning about patients being kept safe, I think we need it feels like there needs to be some urgency on this. So I'd personally appreciate something in the next few days, I think.
Okay, John, thank you.
Thank you.
Peter.
Yeah, a link between the comments from both Kathy and John. I'm grateful for the comments from John. Obviously, we've a sort of vested interest in CQC performance with primary care as well, though we entirely recognise we are, if you like, the minority shareholder here, and so we don't have those direct connections with the CQC whilst they plan and then carry out and report back on inspections. So grateful that we get the information through the paper, but would be helpful also to understand the pace at which, when it comes to not least public messaging on patient safety and the implications of that. Linking through to what Kathy was saying as well, we by no means wish to we take seriously the fact that we do commission public health services. It's just, as I say, we're not the majority commissioner for these practices, and so obviously I suspect it isn't through this forum, but to ensure that we're plugged in if there are actions that we can take to reinforce any messaging or to work with practices to be very clear about expectations from commissioners on requires improvement, then clearly we're very happy to be part of that position if that adds any weight, as it were, to that piece. And linking specifically to Kathy's point on there must be some either low-hanging fruit here in terms of what's working elsewhere, processes and systems that other providers have in place, and also where a practice, I mean, I assume this is happening, but where a practice has managed to make the improvement, as we have a live example here, is it worth, is there legs if it hasn't happened in doing some sort of audit on what is driving the requires improvement, as it were? Are there key similarities in practices that are getting requires improvement actions, and then similarly, are there key themes in what is aiding recovery into a good position? Thanks very much.
Thanks, Peter. Yeah.
Sadie, did you want to come in?
Thank you. Yeah, bit in response to John's point and a bit in response to Peter's point, if I may. So the practice does have an action plan in place to respond to both the previous requirements and this one. What we can certainly do is share more of the detail around that. The locality team is meeting very regularly with this practice, and I'm really pleased that the practice will be able to access some of the support through the Winter Access Fund as well, that we talked about earlier. This is a practice that is very keen to improve, so it won't be any problem providing more detail on what's currently being undertaken over the next couple of days. So we'll do that and circulate that to you all. We're very happy to share the reports. They are available publicly on the website, and people can set up alerts for Norfolk and Waveney so they can see who's coming up for inspection and when inspection reports have been published. I'm really sorry, I've completely forgotten what Peter said and what my point was, so I might just stop talking now. I'm clearly not quick enough at scribbling things down when I'm responding to points. I do apologise.
I think it's about sharing data and sharing good practice, isn't it? And probably
yes,
when High Street is in Lowestoft, we probably need to link into our Suffolk colleagues as well.
We do, and thank you for the reminder, Doris. We have done a series of webinars. Our quality team has been brilliant, actually, in working with the delegated team in preparing training. And we've provided all the searches to practices, learning from the experience of practices like High Street and others that we've brought to you, so that we can help practices make sure that they have the right processes in place in advance of any inspection, and actually because it's the right thing to do anyway. So all of those sessions are recorded and available to practices, and I understand that some of the searches have been updated recently, so we're going through a process of working through those now. So again, we can push those back out to practices so that they can be prepared. And a lot of these issues, as you can see, tend to be about process issues and being able to evidence the process once it's been completed. So that is a focus of the training that we provide to practices. Thank you.
Are there any other questions or comments on the two reports? Peter.
Sorry, I was just waiting a chance there. Apologies, I need to leave at this point, and I couldn't say it in the chat because the chat's locked to me. But thanks for your time, everybody. Thanks very much. Bye now.
Thank you, Peter. I'll move on to the learning disability health check. I think Shepherd, are you taking this?
Yes, thank you, Doris, for that. I would like to start by just appreciating the attention that this priority has on this platform, and I welcome that. And to say also that actually I want to also appreciate the priority that is being given in other platforms, which shows that actually there's more for us to do the more we talk about it. Before I draw your attention to how we are doing, I also want to say that we are in a better place than we were before in a number of ways, in terms of data, in terms of the way we have configured ourselves. You will see that as we go through the data that we have, and also in terms of how we are connected now as a system through the localities, through GP practices. I think we are in a better place. So we'll test that as I take you through to the in the report. I'll deliberately start with the performance section, which is at the bottom of the page, and then we go into the narrative. So if I can take you to that place. So it's fair to say that we are not where we want to be, but if we look at the first bar chart on your left, it actually shows a steady improvement in terms of progression towards where we want to be. So if you look in September, we were at just about 20% in terms of the uptake on people that have had some checks done. And you can see in October that there's that steady upward trend that is going on. Whilst we have laid a lot of structures and systems to improve, as indicated before, we are expecting to see increases at the end of Q3, which is now end of December, and also in Q4, which is end of March. And that is quite consistent across the country. But there's something to notice that in this year, as we go through the charts, you would see some differences in that. So if I can take you to the health checks declines, I think I did take an action from the last meeting because one of the committee members wanted to understand a bit more about what we understand about the declines. And the response to that, it's actually helpful that we've got that challenge because we have looked at it in a more qualitative way. So the team that is set in Norwich, which focuses on quality, has actually had some conversation, and they've written some very good case study about some of the declines that have taken place in the past. So one of the cases was the patient did not want to visit the practice, and they had made it clear that they don't want to visit the practice. So this dedicated team that we have in Norwich actually made contact with the family, and the family made it very clear that he is scared of coming to the practice. And that message was relayed to the GP practice. A home visit was subsequently arranged for that. And there was also a similar case of somebody who was presenting with anxiety and also did not want to go to the practice. Again, that message was relayed to the practice, and it was actually treated from a safeguarding point of view, and arrangements were made. So there are about 4 cases where previously patients had declined, but with that extra intervention from the dedicated team that we have, we've managed to change those. And if we follow to the bottom left where the health checks has been completed, you can notice some strength in Norwich there, and that's where the dedicated team is sitting. And if that probably goes without saying that actually that investment is actually paying dividends in this case. And it's something that we need to think about in terms of how do we help other areas that are certainly not where they want to be, despite all the efforts that they are making. So just picking on West Norfolk. I'm sure there is a question there. What are we doing with West Norfolk? There's a lot of activity going on there, a lot of toing and froing in the background between the CCG and CNH and other. So there will be something that we'll be able to update at the next meeting once we've got some firm plans to strengthen that. But I would like to probably leave you with by saying what we are seeing is positive. The foundation that we have laid is strong, and we should expect to build on that in Q4, Q1, and the following year. So that is where I would leave you with, but also to notice how we are doing against the other systems. So we are not too far away. We are there, but I'm more encouraged in the next quarters coming and also in the new financial year. I would stop there for any questions or comments or challenges.
Thanks, Shepherd. Are there any questions for Shepherd? It's really good to see the data. It's much clearer in the way it's been set out. So thank you for that. John.
Yeah, thank you. And as Dora said, it's a clear report, Shepherd, so thank you for that. I suppose my concern would be, I think you said we're slightly behind where we would want to be. I'm not clear where we think we would want to be at the moment and where we think we'll be next month, the month after, based on the actions we've got in place. So I'd really like to see a trajectory on this that shows how we're planning to get to 75%, or ideally actually to 100%, recognising that some people may decline, so we may get below 100%. But so I suppose there's 2 points there really. One is, I think, clarity on the trajectory, and a sub part of that is clarity on the actions that we're taking that inform that trajectory. So we're clear that things are happening in the background, recognising all the capacity issues that there are in primary care and the other competing pressures. Yeah, and also, I suppose, just a sense of, are we just targeting 75% or are we targeting 100%? Because if we're just targeting 75%, there's over 1,500 patients that we're saying we're not going to be giving health checks to. Thank you.
Thank you for that, John. In terms of, I'll start by saying it's not going to be a straight line kind of response in terms of what we expect in Q1. And if we perform about 15%, then we would land it times 4 of that. But what we know is last year, the team was successful to meet the national target of 67%. They landed at 68.8. So we've got that trend that shows actually we were able to do that. But obviously that is not our ambition as a local system. What we want is to make sure that everyone gets the chance to be checked, and also improvement plans are put there. So if we work from last year, and look at the resources and what we have now put in place, you would certainly argue that actually we are in a better place. We should be able to land beyond or just about 75%. And if you notice, probably Norwich was the worst performing, if you may recall, from last year. And this year, you can see actually that Norwich is actually leading. So on the balance, you would actually see us probably way above 75. I appreciate that we have not provided the actions for each locality, but we've got quite detailed plans from Norwich, from almost all the localities. And we are fully aware of the challenges that they're facing in terms of the workforce, the gaps that are in there. And I think if I probably take you to the narrative where we have put something on the current position, the difference between probably last month and this month, what we have also done is to start working on the declines from that prompt that we got. And so that will certainly make some improvements. Then we've also had a discussion with the chief nurse, Kath, to actually write to all the practices that to encourage them on the work that they're doing. And also, we've also had some discussion with CQC colleagues around the people with learning disabilities. And we are starting to see that reports from CQC are making reference. So, for example, Upwell, if you look at the report that was presented, one of the areas that CQC acknowledged was around the quality of annual health checks that are being done, which is really positive that you're starting to see learning disabilities featuring in almost areas as priorities. And there's also fantastic work that Opening Doors are doing. And at some point, I think we'll be looking at to bring some of the work that they're doing. Sometimes I think I do get the sense that I'm not doing justice to the hard work that is going on in the system, and I need to find a way to bring it here so that those assurances can be provided to the members.
Thank you, Shepherd. Kathy.
Sorry. Yeah, thanks, Shepherd. I mean, it's really positive progress. I mean, I would echo John's comment about ambition. And thank you for this focus on quality. I think it's really developing this agenda. But I guess I was thinking while you were talking, I chair the Quality and Performance Committee. We focus a lot on people with learning disabilities as well. You know, we're looking at, you know, the safeguarding adult reviews and the 3 tragic deaths that we've had recently, and also things like what used to be called LEADER and the mortality review panel. And one of the things I was thinking is the last panel that I went to, we had a gentleman who died of constipation. He'd been constipated for 8 years, and he'd had his check every year for those 8 years. And so I guess, you know, the thing that I was thinking was, you know, yes, we need to be ambitious. Yes, we need to push for 100%. And yet we mustn't hit the target and miss the point of why we're doing this, which is to improve quality outcomes for this very vulnerable group of people. And I just thought, you know, Shepherd, as you're talking about maybe broadening out this work, some bit of join up between what the quality and performance team are doing so that we can look at, are people who are having their checks actually getting better outcomes, or conversely, are people who have bad outcomes getting their checks or not? Because I think there's this story can run a bit further, I guess, is what I'm saying. Thank you.
Thank you. Noted. Thank you.
Bill, do you want to come in?
Thank you. It's really heartening to see this progress, and congratulations to everybody. But it does seem to me now we have a blueprint, you know, around what's been going on in Norwich, and you know, in terms of our ambition for this piece of work, you know, what would stop it being just agreed that we're going to roll it out across the whole of the system? Because we now can demonstrate a result. So why wouldn't we apply it? And if it is a decision around money, then maybe that's a decision we should escalate to say, right, well, this is what we've done. It's worked here. We now need to do it everywhere. And this is what it's going to cost us. And it go, you know, it be decided upon rather than it sort of trickle out. It seems to me we've done the hard work.
Bill, Sadie, did you want to come in?
I would, thank you. Sorry, Shepherd, if I'm about to interrupt or say what you were about to say. I think Bill raises a really good point, and we have, I mean, clearly a Norwich-based team is going to struggle to sort of cover our whole geography when they're sort of roving out and about. So it would perhaps result in increasing resources going forward, and we would need to have a think about making the business case for that. We have, as part of our winter access funds, put in additional learning disability nursing support, which would focus in each of the localities. And I think the aim for that is, because it runs till the end of March, to really try and support and accelerate some of the work that's been done so far, learning from some of the good stuff that Shepherd has shared about what's actually made a difference. And again, I think, you know, seeing how that works in each of the localities will really help us look at how we commission this going forward, and whether we've got the model right at the moment. So I absolutely agree with you, Bill, and where things make sense, we should just roll them out. But, you know, we will need to think about, and John will probably say this, how this fits within all of the priorities across the CCG and the system when we have limited funding available.
Thank you, Sadie. Kathy.
It's a small point, but an important one. You know, workforce is my thing. Learning disabilities nurses are in really short supply because we stopped training them because there were no jobs for them. So if we're thinking about improving services to people with learning disabilities, I guess we need to start advertising that now, so that at least we'll get some candidates through the universities in order to employ them.
Thanks, Kathy. John.
Yeah, just a couple of points picking up on what Sadie was saying as well. So one is, from the financial point of view, I wouldn't want money to be a barrier to us coming up with the things that we think would make a difference. And Bill's comment that at least then we take it forward to a decision-making forum to decide whether that's the right thing to do. Also, as we've mentioned earlier, there is money around this financial year. So if there's something we could do as almost as a one-off, actually for a group of patients that maybe haven't had the checks that they should have had over the last 2 or 3 years, that we could do by the end of March, I think we've got the opportunity financially. The big problem is workforce, clearly, isn't it? And linked to that, I suppose it's just a reality check. Does our plan rely on primary care doing all of this work in the remaining, four months of the year? Given all the pressures that we've heard about in terms of primary care, is there a contingency? Are there other people at play in this? I suppose I'm not clear on the plan. Who is the workforce doing this?
It is the GP practice.
Yeah, can I make a suggestion there? I mean, the obvious way is to grow our own, put in a load of nurse trainee posts via the apprenticeship route, and have somebody like NCH&C deliver it, because they've got the infrastructure and it will take the pressure off primary care. I think it's a really important point, but we need to be a little bit less compartmentalised in our workforce planning, I'm guessing.
Yeah, I think I would quite like to see, I kind of scratch my head as to why it's backloaded to the end of the financial year, or this work every year, when it then coincides with winter and all the other pressures. You know, why cannot we not spread it out and do some of the work? I mean, not me personally, I'm no good at this, but in the sort of, you know, summer months when, and I know people need to go on holiday and everything, but it just seems, as a layperson, it just doesn't seem very sensible. But maybe I've got the wrong end of the stick on that. There's probably a very good logistical reason why it's done that way. Sadie.
Well, Rosemary might give the very good logistical reason. I think from me, I think it's about when it was introduced as a service. actually, because this service has been around for years and years and years, and one of the bits of good practice which the project team have been sharing is the review by birthday, which kind of spreads out the activity across the year and doesn't leave it all to the last minute when there are conflicting issues, as you say. And there are certain operational considerations which I'm not an expert in how we move from the way you currently do it to the way you need to do it going forward. But I think, I mean, it's been, from my point of view, it's been a really helpful discussion. I think, you know, this work is just going to continue to build and continue to grow as we move it forward. It's making good progress already, but we certainly haven't nailed it yet. I really like Kathy's suggestion about apprenticeships through NCHC, and I know that's something that the workforce team are really keen to develop. So we'll have a chat to them about LD nursing apprenticeships and see, you know, how quickly we can look at that and how soon that might come on board. But I guess in response to other questions, I think we probably do need to have a bit of a think about Plan B, because as you say, the pressures aren't going away yet, and much of our focus so far has been around how we support general practice to improve uptake. And actually what we need to perhaps be able to offer is further support around that for those practices who can't offer all of the checks that they need to for whatever reason, or for people who might prefer not to go to their GP practice perhaps. So we'll perhaps have a chat about that offline, and obviously we have our two practice manager colleagues here as well that I'm sure will have some views on that too.
Thanks, Sadie. I'm going to take one last one from Rosemary and then I'm going to move on. Sorry, you're on mute, Rosemary.
Sorry, I was just going to say, I don't want to disappoint. I'm not sure I've got a good logistical reason as to why we cram it all in at the year end. I think some of it, to be honest, is human nature, dare I say it. You know, some people work better when a deadline looms. So there's always this, it's always been, ever since any sort of enhanced service, anything like that was introduced, it's always been in the last quarter, there's been a scrabble. Certainly, I think practices that are moving towards date of birth recall, that helps, because that helps to spread the workload throughout the year. But I think some of it is, dare I say it, you know, human nature. The mind is focused when we get to January. We're in the financial year, if you like, of when the deadline is. And it's difficult to get around that. But so date of birth recall does help spread it, which is what we're moving towards.
Okay, thank you. Okay, James, last one, because I need to move on. You're on mute as well.
Just one tiny example of the things that lead to this crazy scenario is, for example, System 1 won't give you an update of where you are for your year to date until September, October time. If it was to, because that's how long it takes. And then historically, we've always been given service specs in June or July for the year ahead. So we're always running. We don't know. Most of the time, probably April, May, June, we do things on the basis that our commissioners will continue to support the activity and we have to take it on trust. So there's a whole host of reasons why these things happen in this way historically, and so that it tends to bulge towards the end. At St Stephen's Gate, we have taken the view that we are going to move towards birth month, but it takes 2 or 3 years to go through that process.
Thank you. Thanks for the report and thanks for all the contribution on this. It's obviously an issue that, you know, we all take very seriously and want to improve for our population. On to the prescribing report, Michael.
Thank you, Chair. Okay, so I'll take the paper as read, but just a few things to highlight in terms of prescribing performance. Age normalised cost. So we use the benchmark of performance across the east of England, which tends to go with deprivation. We've moved from 5th highest to 6th highest out of 12, so very nearly in the middle. So that is an improvement in normalised spend compared to our peers. there's some things about the cost pressures, and Hein asked for an explanation of category M. So this is there's a drug tariff which lists various categories of drugs and how the reimbursement is calculated. Category M is a M for margin, so it is how the Department of Health remunerates pharmacies for delivering the pharmacy contracts. So it's quite a peculiar system. So they put the prices, they put funding through medicines costs. So when a prescription for paracetamol is written, there's an element of profit there, which is why when we talk about self-care, we say it actually costs the NHS a lot more to prescribe paracetamol than it does for a patient to buy it, because you can buy, 32 for 32p, whereas it costs a couple of pounds for a similar quantity for various reasons. So it's a way of forcing income into pharmacies through a relatively random list of drugs. I'll try not to be too disparaging, but it would be better if they just wrote them a check, or provided the funding, rather than skew the system and make budgeting quite difficult, because it tends to go up and down in quite a random manner. But enough of category M. So dependence forming medicine. So there's also a little bit of good news in dependence forming medicine. So high dose opiates, we've moved to 81st from 79th last month in terms of high dose opiates as a percentage, which is good. Still got some outliers across the patch, and when my colleagues are visiting, they will highlight that, which I know is at the moment something perhaps you feel you can't work on too much, but it's something we need to keep working on because it's the right thing to do. Gabapentanoids, as discussed, we aren't a national outlier on this, so we could justify taking it off the risk register at some point. So we've stayed at 25th nationally. Hypnotics and anxiolytics, so it is an improving position for the CCG. You can see on the first graph we compare against the top 5 in the country, and our trajectory is moving closer to the trajectory of the next nearest. So maybe when January, February data comes out, we will have moved down at least one place. And the next graph shows Norfolk and Waveney red line compared to national blue line. We are moving closer to national average, but we're a long way off it at the moment. So some good news there. And similarly with antibiotic prescribing, the outlier visits that we've had and the audit work that we've done and conversations with practices on using the correct formulary for antibiotics has paid some dividends. So our top 5, all of our top 5 practices, 4.3 if you look there, have improved, and Burnham Surgery has gone from being the top in terms of broad spectrum antibiotics to going to the bottom of that list now. So they were the national outlier at 100th percentile nationally on their use of broad spectrum antibiotics. Still haven't had a meeting with Litcham and Munsley, but they have improved. There is a new target for volume of antibiotics. So this is the one that says Visual Analytics Prescript. You can see there's a blue line on the left-hand side bar chart, horizontal bar chart. There's another green line, and there's a new green line. And every PCN, apart from 2, West Norfolk Coastal and Fens and Brex, are achieving the new target in terms of actual antibiotic scripts they're giving out. So we're actually not in a bad position in terms of volume of antibiotics, but there's still some work to do on managing our outliers on the broad spectrum antibiotics, whose use should be restricted to in line with formulary, just to maintain their effectiveness long term, as it is a public health issue. If we use broad spectrum too often, we'll get more resistance to antibiotics. And another piece of good news, all practices have signed up to the prescribing quality scheme. They've probably got very limited capacity to deliver much of this at the moment, but that's a common theme, I'm afraid, throughout this meeting. But it's good news that they've at least said that they would like to deliver it and would like to achieve the targets. So happy to take comments, questions.
Thank you, Michael.
Okay.
Are there any questions for Michael? You stunned us. Oh no, you haven't quite completely stunned us.
Okay,
Sadie. Sadie's been unstunned.
I'm really sorry to ask this, Michael, because I should know. But I got a little bit confused looking at opiates, gabapentanoids, and then hypnotics and anxiolytics, and what position is something that we think is a reasonable position and what is a position that we're concerned about, because we've got gabapentanoids, I think, on our risk register, but we don't have high dose opiates, or do we? I've forgotten now. But
no,
that improved to 81st still seems quite a long way down.
So 81st out of what is it, 106 organisations. So first is worst.
Ah,
Yeah.
right. So
okay,
we measure different ends of the position on the three different.
We do, but
Okay.
24th percentile nationally. So that's but well below national average, which is 50th percentile by definition. So that's that particular measure of high dose opiates is we're actually quite good on. But as I say, there are some outliers across the patch which we have conversations about and we've got meetings about, etc. So yeah, third nationally on hypnotics and anxiolytics is the one that needs to remain on the risk register until we've got that under control. But that is a long-term piece of work.
Thank you.
Okay.
Any other questions, comments? No, thank you very much, Michael. Good to see progress and your very interesting explanation of category M. I'll move on to the annual delegation report. Shepherd, are you taking this because Fiona's had to step out?
Yeah, thank you, Doris. I will introduce the paper, then I will ask colleagues to chip in their respective areas. I guess this is probably, we are almost in the second to the end of the year, but this is reflection of last year, financial year. And it's for the committee to note the activities that were involved last year. There is no significant activity that I just want to draw the committee to, but just to ask the committee to note what happened last year in terms of the way we were configured in terms of commissioning, then the changes that took place in terms of the contracts and the movement around the staffing, and the contractual changes in terms of the extensions that were approved. And most of the activity would have come through this committee for approval. So it's a record of what happened last year. Unless if other colleagues have got any kind of areas to highlight from their respective areas, I would probably leave that time for that now.
Thank you, Shepherd. It's always good to be reminded what happened last year. Just out of my sheer ignorance, what is a 24-hour retirement? Can we all do that?
It's an NHS thing. You leave for 24 hours and come straight back. You essentially take your pension and then you can come back. Yep.
Right, okay.
Yeah, that's exactly it. And obviously for a GP who's in a partnership, there's a little bit of paperwork because they have to leave the partnership, rejoin the partnership after 24 hours. So it's a little bit of an administrative thing for the team with a GP partner.
Okay, maybe I shouldn't have asked. Thank you. Are there any other questions, comments? No, thank you very much for that. Moving on to, last but not least, the finance report.
I'll take that. So I'll take the report as read, but just draw your attention to some of the key points. So the total spends for prescribing in primary care as at month 7 is 900,000 adverse to plan for the full year. This is a deterioration from month 6 of 800,000, of which 600,000 that is within the prescribing areas and 200,000 within primary care. The financial summary shows the breakdown of this 900,000 adverse variance at a subdirectorate level, with 1.8 million prescribing overspends being offset by 900,000 of primary care underspends. The detailed variance analysis shows that the GP prescribing variance narrative, with the major drivers identified as growing DOAC costs, practice variation, and efficiency slippages. The £1.8 million variance does also include a non-recurrent prior year benefit of 1.5 million, meaning that the underlying variance is 3.3 million. There are ongoing efficiency initiatives to reduce this prescribing overspend in both this and the next financial years. These are being explored and developed through the Prescribing Efficiencies Delivery Group, which meets every 2 weeks. A number of existing schemes are developed utilising software such as Optimize and carrying out prescribing switches to reduce those costs. Moving on to the COVID Capacity Fund, there's a page there detailing the scheme, and the majority of that £2.32 million allocation has now been paid out to practices. On the System Development Fund page, this details the individual SDF schemes and is again shown predominantly on plan with some minor variances. Then within delegated co-commissioning, this shows an overall positive variance against plan. However, this has deteriorated from month 6 due to additional impact in investment fund costs that have increased against the allocations that were given to us at the beginning of this year. This is a similar situation to what we've seen with QOF, leading to the overspend. Overall, the position within delegated is offset through the release of prior year accruals, giving us an overall positive variance to plan. However, we can see that there is an underlying funding problem within delegated primary care, which is being offset by non-recurrent means. Finally, on the GP prescribing page, that gives a detailed breakdown of the drivers of the adverse variance. As previously stated, this has deteriorated since month 6. That was the major points. Are there any questions?
Thanks, James. Very clear run through and report. Hein.
Thanks, James. A question for you, maybe Michael. The 2.5 million targeted for efficiency in GP prescribing. So it says plans are in place. Any sense of whether we're going to meet that? You had a discussion in recent finance committee on it, but interested on the latest and greatest insights you or Michael may have.
Michael, do you want to comment on the meeting?
I haven't attended a meeting. I'm due to attend a meeting in the near future, so I'll have a clearer picture. But I mean, plans are in place, and delivery is expected. I don't know if you want to elaborate on that.
I think, yeah, absolutely agree with that. Plans are in place. I think resources is our major blockage with that. So a lot of the plans require resource to do the switches or to do the various work, and that's where we're strong. I think we spoke many times in the past about that sort of pharmacy resource that we don't necessarily always have in the CCG. We're looking at lots of different options to do that. There, one of them is to use external resources to do that as well. Some of the piece, and also look at what PCN resources could be used. So all of those are still have to be on the table, I think, at the moment.
Okay, thanks.
Any other questions? No. Thank you for that summary. I'm sure a lot of it is work in progress, and hopefully some of those schemes will come in place, and we can claw some of the shortfall back. I'm not aware of any questions from the public, unless anything's come in since we started at 1:30.
No.
Thank you very much, Sarah. So is there any other business from anybody? No. So seeing we are in December, I wish you all a very happy Christmas and a new year. I hope you all manage to get some break, even if it's a couple of hours. I hope it's more than a couple of hours, and come back refreshed in the new year. And I look forward to seeing you all in January. For those of you who are unfortunate enough to have to stay on for part 2, we'll reconvene in 10 minutes. So let's say 10 to 4. But thank you all. And